Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the HemOnc podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
No Vivek, and I'm Dan.
That was weird to not have Vivek do his little bit of the intro, but alas, me and Dan are here, and we're excited today. We have another new series coming at you, this time talking all about sickle cell disease.
Yeah, I'm excited to get into this. We're doing finally a comprehensive series on a benign heme topic, which is exciting. And sickle cell is actually one of the first disease states I ever learned about. Back when I was in high school, I did a research internship at a hospital in the Bay Area that was the Sickle Cell Center. So our first lectures were all about sickle cell disease.
Well, that's perfect. So we're definitely going to draw on you, Dan, to walk us through the pathophys of this disease, the biochemistry of this disease, and of course, we'll be talking all about management of this disease as well. So without further ado, let's roll the first of our episodes to Introduction to Sickle Cell Disease.
So, Ronak, you're in a different place.
Yeah, I mean, our listeners can't tell, but the background is a little bit different than what these guys are normally used to. Vivek's not on the call today. He was a little bit tied up with some clinical work. So just me and Dan today. But Dan, you were very astute for noticing, and it's not a virtual background. This is real. This is the first episode that I'm recording from the city of Philadelphia.
An hour time difference and many more hours of travel away. Wouldn't be my first choice, but that's how it goes.
It's been fun, to say the least. This recording is happening during my fun employment period, so it's been all sorts of adventures, and it's weird not working right now, but I'm thoroughly enjoying all of this. I am excited to get back into some sense of normalcy, to get back on our recording schedule with you guys, and obviously even more excited because we have a benign heme, classical heme topic for us today, talking all about introduction to the management of sickle cell disease, a huge topic, a topic that deserves, its own series or its own podcast, to be completely honest with you, but we will do our best over the next few weeks to walk our listeners through this disease, and I'm really, really excited to get into all of this. So Dan, I have a case, maybe I can use this to work off of for our discussion today, and then we'll take it from there. Does that work?
That's great.
All right, cool. So I have a 20-year-old female who presented to hematology clinic to establish care for her sickle cell disease after recently moving to the area when she transferred schools. Her genotype is hemoglobin SS. Her uncle recently passed away at age 41 related to complications of sickle cell disease, and she's motivated to learn more about her disease. She asks you to explain what sickle cell is doing to her blood. So Dan, if you get a question like this, I mean, this is a beast of a question. How do you even approach this, and what should we be thinking about here?
Well, I usually start with just apologizing to the patient for the amount of detail I'm about to go into. But of course, I always say to stop me at any time if you're bored to tears by all of this. But you really do have to go back to some of the basic science to understand what's going on with sickle cell disease. So I'll ask all of you, the audience, the same thing, to bear with us. This episode will be going through a lot of that preclinical, undergraduate level stuff that you learned about, but it's important. So to start off, we have to remember that sickle cell hemoglobin, like so many other variant genes affecting red cell biology in general, is an adaptation to the malaria parasite. We've co-evolved with this parasite for the past 10,000 years or so, and we've accumulated a large number of adaptations as a result. Before we delve into the sickle variant of hemoglobin, let's talk a little bit more broadly about what hemoglobin is. We'll have a beautiful diagram of the molecule in our show notes, but you'll have to use your imagination if you're listening along. Recall that adult hemoglobin, also called hemoglobin A or hemoglobin A1, is a metalloprotein comprising 2 beta-globin chains and 2 alpha-globin chains. We have 2 beta-globin alleles, the HBB gene. They're located on chromosome 11, and we have 4 alpha-globin alleles, the HbA gene, which are located on chromosome 16. Beyond these 2 main ones, there are a number of different globin genes that are similar to beta-globin that exist on chromosome 11. We have HbE, which is involved in embryonic hemoglobin, HbG1 and G2, which both make fetal hemoglobin when combined with alpha-globin chains, and HBD, which makes a variant hemoglobin A called hemoglobin A2. The protein component of hemoglobin is bound to 4 heme groups, each of which has an iron atom at the center. And it's that iron atom that actually holds onto, it coordinates oxygen molecules. And remember that when an oxygen molecule sticks to that iron, the whole enzyme changes conformation. And that conformational change also changes the affinity of hemoglobin for oxygen. So each successive oxygen molecule that gets loaded on changes the amount of sort of avidity, or it increases the amount that the hemoglobin protein wants to hold on to oxygen. And it's that variable affinity of hemoglobin for oxygen that results in the classic S curve that you all probably vaguely remember from your preclinical studies. And there are a few other factors that can fine-tune that oxygen affinity, sort of increasing or decreasing depending on the direction you go. And those include temperature, pH, so acid-base balance, and the presence of a sugar derivative called 2,3-BPG. And that gets synthesized through the glycolytic pathway and kind of helps us adapt to changes in altitude. All that fine-tuning optimizes the hemoglobin molecule's ability to soak up oxygen in the lungs and dump it off in the tissues. The sickle cell disease state results from an abnormal variant in that beta globin chain. Specifically, it's a substitution of valine in place of a glutamate at the 7th amino acid. Previously, this was actually referred to as the 6th amino acid, sort of silly historical reasons for why that is and why it changed, but any papers sort of prior to the early 2000s will probably refer to it as the 6th position. It's not a mistake. This is just a change in the way we count the amino acids in the hemoglobin molecule. But regardless of what position we say it's at, this change makes it such that the hemoglobin molecule polymerizes when it's deoxygenated. So these long crystals can form inside of the red cell. And it's those long crystals forming, polymerizing, that cause the cell to deform into that classic sickle red cell shape. The sickled red cells themselves are a huge problem generally in the body. They are highly pro-inflammatory, so they recruit a lot of immune cells and cause diffuse immune activation. They adhere to the endothelium and cause endothelial dysfunction through a variety of mechanisms, and they can spontaneously break down, sort of lysing inside of the blood vessels. And remember that intravascular hemolysis is a huge deal. It causes endothelial dysfunction all on its own and vasospasm because of free heme sort of scavenging nitric oxide. And it's also highly prothrombotic because broken down red cells, those shards of membrane have exposed phosphatidylserine on them, which is really, really intense in terms of thrombin generation. So a lot of downstream consequences of this sickling, both directly related to the sickle cell formation and because of the consequences of intravascular hemolysis. And so all of that in mind, because the deoxygenation is what causes that hemoglobin S, the sickle hemoglobin, to polymerize, and because those sickled cells can obstruct blood flow in the microvasculature, you can end up with this positive feedback cycle where progressive vasoocclusion causes increased hypoxia, which causes more sickling, which causes more vasoocclusion. Layer on top of all that diffuse endothelial dysfunction and immune activation, and you can end up with these sort of vasoocclusive crises. These are events that manifest as either hypoxic respiratory failure, diffuse bone pain from marrow infarction, acute stroke, liver failure, rapidly progressive multi-organ failure, chronic hemolysis also, just outside of these crises, and sort of low-level intermittent vasoocclusion also causes other issues, chronic anemia, typically in the 6 to 10 grams per deciliter range, functional asplenia over time, chronic kidney disease. And we'll talk all about these complications in a huge amount of detail in our next episode, but suffice to say, a lot of things can happen when these sickle cells form and related to these sickle hemoglobins.
Dan, that was super comprehensive, and I think you tied that nicely together, just highlighting how interconnected this whole disease is, because at the end of the day, the underlying problem is that patients have abnormally shaped red blood cells, and red blood cells go everywhere, and so you can imagine that there are going to be complications in literally everywhere and many organs in our patients. And so this is going to play a big theme as we talk about management of the disease, both in the acute setting and also in the chronic setting. So guys, just keep all of that in the back of your minds. So individuals that are heterozygous, so Dan talked about the homozygous patients. Individuals that are heterozygous for this mutation are said to have sickle cell trait. And this is found to be 90% effective against severe malaria, including cerebral malaria, and it's 60% protective against malaria requiring inpatient management. And so as a result, the epidemiology is such that the variant is prevalent anywhere there's high rates of malaria, which markedly is seen in sub-Saharan Africa, but also in India, Greece, and the Middle East. And in fact, there's an estimated prevalence of around 7% of sickle cell trait in the African American population. If the non-sickle beta chain is normal, most heterozygotes will not have any symptoms and will actually have a normal baseline hemoglobin concentration. There is, however, an increased risk of kidney issues with these patients with sickle cell trait. Patients with sickle cell trait also frequently have hematuria, likely from these small infarcts in the kidney. Again, we said that this is an issue with the blood, right? And anywhere where there's small blood vessels, as Dan described, you're going to have issues with these prothrombotic molecules in circulation and causing issues. So the kidneys are going to be innocent bystanders in this situation. What we believe is that fundamentally there is a renal specific vascular issue, and there were studies on sickle cell trait patients that suggested 50% increase in the risk of CKD compared to the general population. And finally, there is a rare type of kidney cancer called renal medullary carcinoma that basically only occurs in patients with sickle cell trait. It's a very aggressive cancer, and although there are other reasons for hematuria in patients with sickle cell trait, it's always important to work these patients up with appropriate imaging to make sure that cancer is not present. And I will say that this question has certainly come up on my question banks in preparation for boards. Renal medullary carcinoma is more common in sickle cell trait. We typically don't see that in sickle cell disease. So this is just something good to stow away in the back of your minds. So the symptoms classically associated with sickle cell disease emerge when there's no normal beta globin chain around to dilute the sickled beta globin. Most commonly, this is going to be in patients that are homozygous for that sickle cell mutation. And we refer to these patients as having hemoglobin SS. So you may see that written as HbSS. Besides hemoglobin SS, the hemoglobin S gene can cause sickle cell disease when a patient is a compound heterozygote with another variant beta globin gene. And some common ones include hemoglobin C, for instance, which is found in West African populations. And it's believed that 17 to 28% of individuals in West Africa harbor this mutation. And we call this hemoglobin SC genotype. You can also have a variant where one of the beta globins is a beta thalassemia variant. And these are going to result in either a beta plus or a beta zero thalassemia. So we call these patients hemoglobin S beta plus or hemoglobin S beta zero genotype, respectively. And finally, there is a less common, but the hemoglobin O Arab warrants mentioning. And this variant in combination with hemoglobin S produces a particularly severe phenotype denoted hemoglobin S O Arab. And this can be bad or worse than hemoglobin SS in terms of rates of vaso-occlusive complications. So essentially what we're saying here is that, in hemoglobin SS, sickle cell disease that we traditionally think about, you have two abnormal beta globins that harbor that mutation conferring that sickled cell shape. But let's say somebody has one abnormal sickle cell gene, but they have one abnormal beta globin gene that has some other mutation. When those two genes come together to then make the hemoglobin molecule, that is still going to have implications. And so hemoglobin C, hemoglobin S beta thal, and hemoglobin SO Arab are examples where you have one abnormal sickle cell gene and one other mutation. So we call these patients compound heterozygotes. Hemoglobin SC disease and hemoglobin S beta thal genotypes produce milder phenotypes than hemoglobin SS. So Dan, we've discussed these different mutations that can arise that can result in manifestations of hemoglobin SS or some compound heterozygote state like hemoglobin SC that we talked about and hemoglobin S beta plus. Can you describe to us what the difference is on a clinical level? I mean, we've certainly talked about the genotype, and we can always sequence patients to figure out what their genotype is. But on a clinical level, what kind of things are we seeing that are going to differentiate these patients potentially?
A really important thing to remember is that even hemoglobin SS, there's a broad range of phenotypes that can result. And that goes doubly for all the various different compound heterozygous states. But Broadly speaking, hemoglobin SC disease and hemoglobin S beta plus genotypes produce milder phenotypes than the hemoglobin SS. They have less frequent and less severe complications, but they can still have any of the same complications as those with hemoglobin SS. So think vaso-occlusive crises, pulmonary complications, that sort of thing. It just tends to be a slightly reduced intensity of those same complications. That makes sense, right? The hemoglobin S is still somewhat diluted, but the sort of partner beta globin gene is also not normal. So it results in a disease phenotype still. Hemoglobin S beta thal 0 produces a phenotype that is nearly identical to hemoglobin SS. And this also makes sense, right? Because now the beta thal 0 is a null mutation in the partner beta globin gene. So they have one hemoglobin S beta globin gene and one beta globin gene that's not really producing anything at all. As a result, their fraction of hemoglobin S is still basically the overwhelming majority of beta globin chains that's out there. So those folks will have a very similar phenotype to hemoglobin SS. There are obviously a broad range of other potential beta globin variants that are out there that we won't really talk through. Hemoglobin S O Arab, as you mentioned, is a particularly clinically relevant one. There's hemoglobin D Punjab, also called hemoglobin D Los Angeles. They're the same thing. We've kind of, people discover these different variants. Sometimes we figure out later on that they're the same. So it's very confusing to try and keep track of every little infrequent variant that's out there. But these ones are hemoglobin SC and paired with the beta thals are probably the most common that you're going to run across.
That's super helpful. And I think we'll provide that link to look up some of these other variants in our show notes in case any of our listeners are curious, just to keep in their back pocket should they ever need that. We also mentioned that ultimately it is helpful to know what genotype our patient actually has. And so out of curiosity, if we do see a patient with suspected sickle cell disease, granted, we are adult physicians and it's unlikely that we are going to diagnose a new sickle cell disease for the very first time, but stranger things can certainly happen. And so with regards to the workup for a patient that doesn't yet have a genotype, how do we go about doing that?
This does come up more often than you'd think. Oftentimes, if someone's coming in and they're really sick and you just don't have a good concept for what their genotype is, or they're just new to the system and maybe don't remember what it was from when they were a kid, you can still send off these hemoglobin electrophoresis tests, and that's what we use. So as of writing, hemoglobin electrophoresis is still the mainstay of making the diagnosis. Obviously, DNA sequencing, the technology is improving. It's increasingly available, inexpensive, and speedy. And so we may be moving more towards that in the near future. But for right now, we still do electrophoresis. Remember from your biochemistry classes that electrophoresis is a biochemical technique that uses charge differences, so difference in charge between different proteins, to separate those proteins from one another. Because the change responsible for causing sickle hemoglobin involves replacing a negatively charged residue with a neutral one, it allows us to separate these two variants with this biochemical method. Electrophoresis or its related methods, isoelectrofocusing or HPLC, high performance liquid chromatography, they use these techniques to separate different variants and measure precisely what the proportions of those different variants are. I honestly always still feel a little excited whenever I'm sending off one of these tests. Electrophoresis was actually the technique they originally used to discover what was going on with sickle cell disease. Back in 1949, the famous chemist and Nobel laureate Linus Pauling found that patients with sickle cell disease had a different pattern of protein bands when running their hemoglobin on electrophoresis. And they suspected that this variant, this change, was responsible for the disease phenotype. They published it in a paper in 1949, and that's actually one of my citations for the show notes as well. Because this discovery was made sort of at the forefront of our understanding of what these proteins were responsible for and what to look for, sickle cell disease is widely regarded as the first disease that we actually had a true molecular pathophysiology sort of discovered for. So, every time I order hemoglobin electrophoresis, I kind of think about that. And it's like, oh, this is the spirit of discovery in a test order.
The look on your faces and the smile that you have, I just wish our listeners could see because it's literally infectious. Dan is grinning from ear to ear in regards to this. And as Vivek and I like to say, only Dan. So Dan, it's great to know that electrophoresis is so readily accessible. It's something that many of our listeners may have done as part of research experiments while they were in undergrad or in grad school. It can be a tedious process, but it is something that's readily available. So I'm glad to know that that's what we use as our backbone for diagnosis. I know it's complicated, but can you walk us through what we should be looking for if we ever had the opportunity to look at the gel ourselves?
Definitely. We'll make sure we break this down in a table in our show notes. It's certainly easier to work through in a table format. But For anyone who has this test run, the report will list fractions of hemoglobin A, hemoglobin A2, and hemoglobin F. For an individual with normal wild-type beta-globin genes, they'll only have hemoglobin A and hemoglobin A2 listed, normal adult individual. About 2 to 3% of that will be hemoglobin A2, and the balance will be hemoglobin A, maybe a little bit of hemoglobin F from time to time. In sickle cell trait, we're generally seeing in the neighborhood of 35 to 45% hemoglobin S and 50 to 60% hemoglobin A. When these other variant hemoglobins are present, they'll be listed as their own separate column on the result, the hemoglobin electrophoresis result. But if you were to run my blood on there, for example, as someone who doesn't have a sickle cell trait, hemoglobin S wouldn't even be listed on there. It's like, why would I list these other hemoglobins that aren't relevant? But they'll kind of show up as they're found. In hemoglobin SS disease, we'll see 85 to 95% hemoglobin S, with the remainder being hemoglobin A2, so 0% hemoglobin A. If the hemoglobin A2 fraction is above 3.5%, that should prompt you to think more about the presence of a concurrent beta thalassemia. So hemoglobin beta 0 if the hemoglobin A fraction is 0%, and hemoglobin beta plus if the hemoglobin A is present but pretty low. Hemoglobin C can be detected by this method as well, and so hemoglobin SC patients will be about 50-50, hemoglobin S, hemoglobin C. Lastly, as we mentioned before, hemoglobin F, or fetal hemoglobin, is also listed on these reports, and increasing the proportion of fetal hemoglobin is an important therapeutic goal in the chronic management of sickle cell disease, since fetal hemoglobin seems to have really potent anti-sickling effects. We'll talk about that more in some later episodes as well.
This is another topic that does come up on exams, and I know that I got a few questions about this on prior in training exams, also on the question bank. So definitely check out the table in our show notes. Look for patterns that make this, evident. But I think based on our conversation today, hopefully you can appreciate why the numbers look the way that they do instead of just memorizing arbitrary numbers. So let's go back to our patient. She doesn't remember how she was diagnosed with sickle cell disease, but for as long as she can remember, she's had this diagnosis, so she figures it must have been diagnosed in infancy. We review her history, and she only had a handful of vaso-occlusive crises in the past and does not recall ever needing an exchange transfusion or having acute chest syndrome. She confirms that she is not currently taking any medications for her sickle cell disease other than a daily folic acid supplement. She's interested in having a hemoglobin electrophoresis performed, and it shows the following. Hemoglobin A was 0%, hemoglobin A2 was 2%, hemoglobin S was 68%, and hemoglobin F, as in fetal, was 30%. So she's confused when she sees these results. She's always been told that she has hemoglobin SS, and she was expecting to see levels around 90%. So now what do we tell her?
So yeah, this is an interesting result, but it does make sense given her fairly mild phenotype. As we discussed, there's a broad range of phenotypes for folks with hemoglobin SS. Most of the time, we don't really understand why that's the case. Some folks seem to just have worse manifestations of the disease than others, but sometimes there is an additional measurable genetic change that can account for a mild phenotype. And one such change is something called hereditary persistence of fetal hemoglobin. In patients with this concurrent hemoglobin abnormality, their naturally increased levels of fetal hemoglobin production helps counteract some of the detrimental effects of hemoglobin S. And as a result, they have fewer vaso-occlusive complications. Although we're increasing our understanding of the genetic changes that can lead to higher natural hemoglobin F levels, this patient's finding is demonstrative of why the biochemical analysis like hemoglobin electrophoresis can still be helpful in understanding a patient's disease and risk factors, because we can very clearly see this elevated fraction of fetal hemoglobin. Additionally, measuring fetal hemoglobin fractions can be helpful in monitoring response to therapies, as we alluded to before, since there are many that aim to increase hemoglobin F production. We'll talk about that in great detail later on in the series.
Well, thanks to Dan's really wonderful explanations, the patient was happy with her discussion about sickle cell, and she decides that she's going to continue to follow with us in our clinic until her graduation, and thankfully has only required a few inpatient admissions for vaso-occlusive pain crises twice over the next 2 years that you're working with her. So ultimately, a great outcome. We don't like to see vaso-occlusive crises. It is unfortunate when it happens. We will talk about this more in subsequent episodes, but nonetheless, I think overall she did relatively well, and there's a lot that we've learned from her disease in just our discussion today. So listeners, this was certainly a lot of information. We definitely recommend you go back through the show notes just to try to make sense of some of the numbers and the charts and the graphics, and go ahead and take a listen again just to really commit this to memory. You likely will see a patient with sickle cell disease at some point, especially if you're in fellowship or in residency, and potentially in your clinic once you're out there in practice. So it is something that we need to at least be cognizant of. And at the most fundamental level, understanding the difference between sickle cell disease and sickle cell trait, I think is one thing that is super duper duper important. And believe it or not, there are a lot of people that don't know the difference. And now hopefully you won't be one of them after this discussion that we had today. Dan, any final thoughts that you have?
And I think you summarized it very well. Just thanks, everybody, if you stuck around this long in the episode and listened to me drone on about hemoglobin variants. It's one of my favorite things to talk about, but for some reason, people's eyes just glaze over whenever I do.
I think if we linger any longer, Dan may continue this discussion even in more detail. So I will spare our listeners, and I'm just going to call it a day here. So guys, this wraps up another fantastic episode of the Fellow on Call. Until next time, we'll see you all later.
Peace.